Hi, everybody. This is Dr. Ensley. Appreciate you taking some time to walk through some things with us. I'm really very excited about the opportunity we have to launch a new protocol that we think is going to be very beneficial for some of our heart failure patients, and it has to do with how we manage diuretics. There's a little bit of randomness how different providers use diuretics across the system, and we wanted to try taking a more systematic approach to that. And so you can see on the title here, this is our St. Francis Adult Inpatient Heart Failure Diuretic Protocol. And I'd like to take a few minutes here to walk you through that plan. Let me start out by saying this has really been a 6-month project, and I'm sure I'm going to forget some names. Natalie and Tracy Boland and Manuel Calvin from pharmacy and Dr. Regmi and other floor managers, Derek Mitchell, instrumental in getting this up and ready to launch, and so we're excited, and I'll share some things with you. I'm going to start with just some background. So we focused on 2 problems that we perceive in how we address getting heart failure patients decongested using diuretics. And problem number 1 is, where do we start? What's the right dose that we should use as a starting place when somebody comes in with acute decompensated heart failure? And I put up for reference here a study that goes back a number of years. And this was a study that looked at 2 different dosing algorithms. The high dose algorithm here was 2.5 times the previous oral diuretic dose. So if somebody was on 40 twice a day of furosemide, add that up, and their daily dose is 80, multiply that by 2.5, and you get 200, and that would be the daily dose of diuretic in the high dose arm of this study. And I point this out because some of the doses you're going to end up seeing as we go through this algorithm are higher than what you're used to seeing, but they're in keeping with national and international guidelines. So in this study, they compared the lower dose to that higher dose, and this is just a slide looking at creatinine. And the high dose arm did have a little bit more rise in creatinine than the low dose arm, but the magnitude of that difference was pretty small. There were a few more patients in the high dose arm with acute kidney injury, but there weren't dramatic changes in the kidney issues related to the higher dose versus the lower dose. So just a little bit of background. So with this question of what's the initial dose, where do we start? These are ACC guidelines, and you'll see here the initial dose should be from 1 to 2.5 times the daily oral loop diuretic in furosemide equivalents. And so our protocol is going to be built around this. We shaved 0.5 off of that, so we're going to start with a value of 2, as you'll see. But I just want you to understand that the doses we're going to be seeing, while they're higher than what you're used to, they're in keeping with guideline documents. For reference, here's the European heart failure guidelines, and again, they say 1 to 2 times the daily dose with a maximal daily dose of up to 400 milligrams of furosemide. So that's problem number 1. Where do we start? What dose do we pick when we first get a patient in? Here's problem number 2, and I've seen this similar sort of data and slides presented at heart failure meetings around the country. We're not unique in this regard. This is a real patient. Since admit, the input-output tables suggested that they were 15 liters negative. If that were true, their weight should be way down. But as you can see, their weight's only down 3 kilograms from admission. So input-output tables and daily weights, despite best efforts and good efforts on the behalf of nursing staff and techs, they just, for many, many reasons, aren't accurate. So they lead us astray. In this case, if you were just looking at the input-output table, you would have been led to believe, great, we've taken a lot of fluid off. And it probably wasn't true. So that's problem number 2. So here's the summary of these problems. Many providers don't know what those guidelines are for where we start with initial dosing of diuretics, and they tend to start at lower doses than what the guidelines would recommend. And 2, daily weights and input tables are inaccurate, making it difficult to know whether we're really diuresing effectively. I've told many people as we've embarked on this project, there are many times I walk in, I know that other data is not accurate, I really can't tell just looking at the patient, particularly in some of our obese patients. So I end up walking in the room, and the best guide I have to whether somebody's diuresing is I ask them if they peed a lot. We'd like to do better than that. So both of these problems, we believe, lead to slow or inadequate decongestion, longer length of stay, and since we're probably not decongesting them adequately, higher likelihood of returning. So that's the summary of where we are, and we hope that the protocol you'll see here in a minute is going to help us with that. I want to make one comment before I show you these next slides. Many of us tend to think of these medicines, Lasix, Bumex, others, as medicines that make the kidneys put out water, and that's not precisely true. These medicines make your kidneys put out sodium. They inhibit channels in the nephron in the kidney that leave more sodium in the collecting system, and then water follows that passively. So these medicines might be referred to as natriuretics. They make you excrete sodium and the water follows. And so therefore, measure of sodium excretion is a good measure of whether we're getting fluid off. So the protocol we're going to work on here is a protocol that's designed to focus on urine sodium levels. Many of you on these floors have already seen us periodically checking urine sodium levels, and we're going to end up doing that much more systematically. But here's a background study called the ENACT trial. So it was 400 patients in the hospital for heart failure, and they were randomized to standard care versus a protocol that checked urine sodium levels and then adjusted diuretics based on those urine sodium levels. So if the urine sodium wasn't at a certain threshold, around 70 or 75, then the diuretic dose was increased. So here's the results of that trial. The primary endpoint, how much sodium did we get out? We got out more sodium in the protocol group compared to standard of care. And then if you look at net fluid, we got more fluid off in the first 2 days with the urine sodium guided protocol. And then the length of stay was actually significantly shorter when we used that urine sodium guidance. So that's just one study in background. The safety of the study was good. There wasn't a lot of hypokalemia and renal failure. Doubling creatinine as one measure of acute kidney injury, 3.1% of the patients in the standard care arm and 2.7% in the protocol arm. So we weren't nuking people's kidneys, so to speak, by doing this regimen. And so while this strategy is not in the United States guidelines, these are the European guidelines just for reference. And as you can see, it says start an initial dose, doses like we just talked about, and then it says check a urine sodium. And if the urine sodium is in the target range, then we just keep repeating that dose. If the urine sodium isn't there, we double the dose and then recheck urine sodium. So that's in the European guidelines, and that's the concept that we're going to promote in our St. Francis protocol. Here's this protocol. You probably can't read any of this. We're going to go through this piece by piece. So we're going to walk you through how this works. So here's the top part of that protocol. And so there's some exclusions. And so patients are not to be on this protocol if they're on dobutamine, drips, if their creatinine is above 3, if they're in cardiogenic shock, if they're on dialysis or CRT, we're not going to use this protocol. And then these are some starting points. If there's a previous diuretic order, we need to discontinue that. We need to discontinue scheduled potassium because that's going to be part of this. If they're getting IV fluids, we need to stop that. And we need to get a baseline electrolyte panel if it isn't already there. So that's a starting place. And then we need to make sure that we are collecting the electrolyte replacement panel daily. And then as you'll see in the protocol, we're going to get a urine sodium level 2 hours after the first dose, and we're going to get a urine sodium level every day at 800, which is 2 hours after their morning dose of diuretic, which is usually given at 6. So we get a renal replacement panel. We check urine sodium after their first dose. So if they're getting their first dose at 2 in the afternoon. Then we're going to get a urine sodium level at 4 in the afternoon, and we'll make an adjustment dose after that. And thereafter, we're going to check our urine sodium level every morning, 2 hours after the morning diuretic dose. They're going to be on a salt-restricted diet as usual. So that's step 1. Well, I guess that's pre-step 1. So this is what's labeled as step 1. So I walked you through that a minute ago when I showed you the guidelines for where do we start. So this is the where do we start part of our protocol. So what Manuel Calvin has built for us here is we have 4 dosing levels of furosemide. And depending on what your home dose was at home, you're going to track to level 1, level 2, level 3. So this is the 24-hour total daily dose of whatever oral diuretic. Essentially, this first level is for people who are pretty naive. So if somebody was on 20 milligrams a day of oral furosemide, or if they were not getting a diuretic, then, or if they were on 10 milligrams a day of torsemide orally, they would go to dose level 1. If they were on 40 milligrams a day of furosemide or 1 milligram of bumetanide, they would go to level 2. So again, you're going to find out what dose of loop diuretic they were taking at home. You're going to, if they're on BID dosing, you're going to add that up to get their total daily dose, and their total daily dose of whichever loop diuretic, you'll find where it is here, and you go to that level. So that's going to pick their initial furosemide IV dosing. For this protocol, we're going to dose all of this in BID dosing. So let's go to step 2. So once you picked the level, you picked a level here, level 1, 2, 3, or 4. You go here, and that will tell you what the dose of Lasix is. So if you're level 2, you're going to get 80 IV BID of IV furosemide. And then we've also picked a potassium dose for you. So that's why you're going to discontinue any previous oral potassium dose, and you're going to plug in this. And this is dependent on their GFR. So if you're on level 3 dosing of IV Lasix, you're going to get 160 BID. And if your GFR is below 30, along with that, you will get potassium 20 BID. If your GFR is above 30, you'll get potassium 40 BID. So in step 2, we're going to pick the dose of IV Lasix that we're going to start at, and we're going to pick an oral dose of potassium, and you will put those orders in to make those things happen. So that's step 2 of the protocol. Step 3, as we already said, we're going to get an initial urine sodium 2 hours after the first dose. So if their first dose is at 9 in the morning or 5 in the evening, we're going to give that dose. 2 hours later, we're going to get the initial sodium. If that initial sodium is 75 or greater, then you leave that dose the way it is. If that initial urine sodium level is below 75, you're going to go up to the next level. So if they were on level 2, they're going to go to level 3. Level 3, you're going to go to level 4. And there's a caveat here. If you're already at this super high dose and you're still getting urine sodium level, then that's a call to the provider. That's somebody who's not responding to this max dose we've provided. And then somebody's going to add diuril, or they're going to add metolazone, or they're going to put in a swan. They're going to do something different instead of just leaving the patient there, not diuresing effectively. So again, they get their first dose. We check a first urine sodium. So this is the only time we're checking the urine sodium in the middle of the day or the evening. Thereafter, it will be daily urine sodium. We're going to look at that first urine sodium, and we may go to the next level even on that first day in the hospital. So that's through step 4. Step 5 then is on the next day and the day after that and the day after that. We're going to check a urine sodium every day at 8 o'clock, which is 2 hours after their morning dose. And we know that you're not going to hit this precisely, but it needs to be fairly close to that 2-hour time frame. And so we gave you a little bit of a window here, up to 4 hours. but really we want it as close to that 2-hour mark as we can. So as you're putting patients on this protocol, you're going to need to think and plan and talk with them. When you give them that morning dose of IV Lasix, it's a good time to tell them, we're going to get a urine sample 2 hours from now. And so then, again, you're going to have to go to the computer and check that urine sodium level. So if you send a urine sodium level at 8 in the morning, it's going to be available at noon. And then at noon, if you see that, then you can advance to the dose to the next level. So here are some bailouts. So these are exit. If the serum creatinine doubles from baseline or goes above 3, then we exit the protocol. And if they're getting systolic in the 80s, we're going to exit the protocol. And like in that previous, currently on level 4, urine sodium level less than 75, we're going to exit the protocol. So those are exit pathways. I want you to think of how we address diuretics like a car. You can have a car in automatic, the way most of us drive, so you put it in drive and it goes. But if you know how to drive one, you can have a car in manual, where the driver is shifting moment to moment and taking a little bit more personal control. So the way we've always done this is driving a manual. The doctor is looking and adjusting doses and picking a starting dose. This protocol is like putting the car in automatic transmission mode. We're going to start the process, and it's going to run pretty well on its own as long as we're following this guideline and staying inside the fences. So that's the basics of how this runs. One of the things that Tracy Bolin built for us is a flow sheet so that we can track, so that you can track day to day what was done. This is built to look something like the heparin and PTT and ACT flow sheets that you're used to. So each dose of diuretic, it gives you a line here to calculate the total daily dose at home, to write that down. So if somebody was on 40 BID of furosemide, then that's going to give you that 24-hour home dose calculation. And I didn't go through this earlier, but there's a way to connect, if they're on bumetanide, to convert that to furosemide equivalents. And I'll let somebody walk you through that later. I won't get into that level of weeds right now. So you're going to do the initial recording here of what their home dose was, the initial Lasix level. So this is level 1, 2, 3, or 4, the dose we gave, the potassium dose we gave, and what was that urine sodium. And then going forward, every dose of diuretic is going to get recorded, and then we'll record these urine sodium levels. So we'll be able to track over time. We'll probably put a creatinine in here on this flow sheet. So one of the things that I want to mention before we close, every single project that we do and every protocol and everything we build in Epic has glitches. So please recognize, as we start this pilot project in a couple of months, there are going to be issues and concerns. We built this sheet so that there's a section for comments, scribble in the sides. As you identify problems, please help us know about them so that we can fix them. So your floor managers are going to be keeping an eye on the first set of these. People will be at the bedside helping you learn how to do this. But we recognize there's going to be something wrong in the way we built this, and you guys are going to help us identify it and find it and fix it. So here's just some parting comments. This protocol, once we get there, the standard heart failure admission order set will have an option for the admitting physician to click on diuretics per heart failure protocol or pick a Lasix dose themselves. So the admitting physician can choose automatic transmission or manual transmission, his or her choice. As we already described, the protocol includes potassium replacement and monitoring. I forgot to really mention that. So we pick a potassium dose in the protocol, but all of these patients, part of the protocol will be the standard replacement algorithm. So if the protocol says they're on 20 BID of potassium and their potassium today is 3.4, you will go to the replacement protocol and you will give additional potassium above and beyond their scheduled dosing per that replacement protocol. Patients with really severe CKD, creatinine above 3 are excluded. The provider can exit the protocol at any time. Recognize we always expect creatinine to bump a little in most of these people. A mild, moderate degree of acute kidney injury is not necessarily a bad thing in these patients. The nursing flow sheet is there to help identify problems and concerns. So our plan is to run 50 patients through this protocol on these pilot units. So initially it'll be 3 specialty, 4 specialty, 2 north, and 3 north. And once we've collected 50 patients, we're going to look at outcomes and look at your comments and poll the staff and then do any fixing that we need to do and make sure that we're doing things safely and not harming patients. So there's the pilot units. So I said here in this slide, initial round of conceptual training is going to be done now while Epic building. So that's this. The Epic build is ongoing. Early next year, it'll be ready for launch. Right before launch, we're going to repeat some of this training, and somebody's going to create some tip sheets for us so that you can have those. This recording will be available for you to review. And then after we've done these 50 patients, we're going to put together reports, look at the quality metrics, and then see how well we've done. So that's it. A little bit longer than I wanted, so I apologize for going that long. Hopefully this is helpful, and we're grateful for your support, and we hope this is going to help patients a lot. Thanks for everything that you do. Take care.